Good morning, everyone. Welcome to the Illinois Alcoholism and Drug Dependence Association's webinar presentation. Today we have guest speaker Dr. Shane Koch. Dr. Koch will be presenting a 21st Century Challenge, Prescription Drug Abuse Across the Lifespan. Attendees will be in listen-only mode, and at the end of the presentation you'll be able to ask questions by using the chat function. Dr. Koch serves as the coordinator of the Rehabilitation Counseling and Administration Program and Director of Addiction Studies at Southern Illinois University in Carbondale. We're about to begin, and I will let Dr. Koch take it from here. We're new at this, learning how to do these webinars, so if anyone has any challenges or something isn't functioning correctly, you can use the chat box down there and I'll keep an eye on it, and hopefully this will go smoothly. So Dr. Koch?
Alrighty, Mary Jo. Now you're gonna switch me over?
It should be.
I'm still not seeing the list of everybody, but I just see us.
Okay, well there's
so
11.
Hey everybody,
yeah.
Welcome. Yeah, I see. Actually, I'm seeing 13. So I know there's folks out there, but I don't know who's out there. So, so welcome to everyone this morning, and maybe we could actually do a quick chat check-in, Mary Jo, to see who's out there. I suppose if everybody chats at once, we won't be able to get them all on there, huh? So I was hoping I could take a peek at the list. Well, welcome, and thank you for coming. I know this is kind of belated, and this is our belated prescription drug abuse presentation from September, delayed by the phenomenal mishandling of my luggage at Union Station. So thanks for bearing with us and for being part of this morning's presentation. Again, we're going to talk about the 21st Century Challenge. I think prescription drug abuse, if we had been talking about prescription drug abuse 10 years ago, all of us would have acknowledged that prescription drug abuse is a problem, but I don't know that any of us would have put it on our top 10 priorities or maybe even the top 20 priorities. I think we were talking about other things and thinking about other things, and certainly the data that we've been getting over the past 10 years indicates, and the experiences we've been having in our clinical programs indicates that prescription drug abuse is going to be really a significant challenge for us for the present moment and into the future. We don't see any signs that there's going to be any lessening of this phenomenon anytime soon. So the other thing that I think is kind of important to say as an introduction is I don't know of any other time that we've had an expansion of the drug menu that has resulted in such a disparate population. Older adults who are really being affected in a dramatic way, and then we have adolescents and young adults that are being affected in a dramatic way. So it's kind of interesting that prescription drug abuse is targeting, maybe that's the wrong thing to say, that prescription drug abuse populations are expanding on either end of the chronological spectrum. It's, I think, a phenomenon that we've maybe not seen. So when we're talking about prescription drug abuse, with the populations we're seeing the largest increase, we're talking about populations that are very heterogeneous and populations that have their own unique needs in terms of treatment. I think when we're talking about adolescents, we necessarily need to talk a little bit about prevention. And so anyway, I think it's kind of fascinating to me that we have a situation with an emerging problem that's experienced in such disparate ways. So move on here to the next slide. Let me make sure I can get that to go. I think everybody knows how to find me, but just in case you don't, here's my email address, and this link will take you to to I think that's actually the college web page for me, but get you connected to me if you need to. Oh, and that's my band's web page. You can go check that out if you like, I guess. All right. You can also find me. I'm the co-editor of the Rehab Counselors and Educators Journal, and you can track me down through their website or through the journal if you like. Again, what's this all about? Well, I think we oftentimes hear about, the next big thing, and I've been around long enough, I guess, having been in the field now for 20 years, a little over 20 years, that we've had numerous next big things that have come up, and I think prescription drug abuse has the potential to be, if you will, kind of a real emerging issue. It's an issue that I think we're not going to be talking about for 1 year or 2 years or 6 months or a news cycle. It's going to be something that we're going to be dealing with for a generation. And although we've seen the drug culture and drug menus shifting in the past, this shift, I think, is a pretty major shift. It's a shift in terms of certainly the types and characteristics of the substances that are being misused. It's certainly a major shift in terms of acquisition of the substances. With prescription drugs, I think we're seeing patterns of acquisition that we've not seen with other substances in the past. Very interesting, I think, phenomenon, particularly around prescription drug use in adolescents, around how adolescents are acquiring substances, and the impact, kind of non-impact of the drug culture in terms of their initial use and misuse. So I think, again, it's a unique situation that we're experiencing, a real situation that we're experiencing, and I think one that's going to be with us. Again, we talked about in the introduction, the populations that are affected are very diverse. The really dramatic expansion and use of prescription drugs, again, seems to be among young people and older adults. So what I want to really talk about this morning is that there's a number of unique challenges that we need to address that are emerging, and if we were doing it live, to facilitate some discussion about how it's going to affect our lives. And what we'll do is probably stop around 11 o'clock or thereabouts and see if we can work with this chat function on our GoToMeeting, and see if we can't actually get to some questions, because I think there's a lot of things to talk about. I guess in closing, you never want to be negative, but my limited direct experience with this population doesn't make me feel very optimistic about our level of preparedness in terms of providing treatment. It doesn't make me feel very optimistic in terms of the complexity and the needs of the individuals that we're working with. It doesn't appear to me that we're really providing the appropriate and effective means for treatment to the number of folks that really need treatment. There's a huge disparity between those who really need treatment for prescription drugs and those who actually receive it. I think most of our programs have pretty limited knowledge and skills in terms of dealing with this issue. Or I shouldn't say most. Many of our programs do. Certainly our programs in Southern Illinois, we're really feeling stretched to deal with this issue. Having said that, I do have some reasons for hope, I guess, in that we just finished a huge project here with our methamphetamine grant program, and what we've discovered is that many of the processes and procedures we put in place for our program here in Southern Illinois, our meth program in Southern Illinois, has actually been utilized quite effectively by persons who have prescription drug abuse issues. So, it's kind of interesting that we use this evidence-based practice in Southern Illinois for methamphetamine, and as the methamphetamine population kind of dwindled over the past couple of years, we've seen a real increase in the number of folks seeking services who have prescription drug abuse issues or prescription drug dependence issues, and they've actually benefited significantly from our program and have done well. So anyway, moving on here, we've got two populations. We've got older adults and we've got adolescents. Let's talk about older adults first. I think one of the interesting things that we've been discussing, we've had several grants looking at several grants that were funded to do needs assessments around alcohol and drug abuse disabilities among older adults, and also around assessing the capacity of the service delivery system to serve older adult populations in Illinois. And some things we've learned from those projects are that the baby boomers as a rule are a, I think, fascinating population. And when you think about it, the current group of older adults that we have in the United States right now are the same folks who 30 years ago were involved in the 60s expansion in terms of the expansion of the drug menu, and they've been over the past 3 decades the folks who really experienced this overall expansion of the drug menu, the introduction of using more and more medications as part of daily life. There are folks who, one of my colleagues always talks about how drug use in the United States actually changed dramatically with the advent of birth control. That birth control was the first time that folks who were healthy used medications to kind of enhance the quality of their lives. So, I mean, this generation has experienced that whole idea of kind of better living through prescription drugs, incredible expansion of the drug menu. They've had more experimentation with illicit drugs and licit drugs than probably any other generation in the history of the world. I think it's interesting. Sometimes we'll go and present, we'll talk about older adults, and we'll talk about people over the age of 60, and folks in the room get resentful because they don't consider themselves to be older adults. And the reality is that I'm at the tail end of the baby boom generation. This generation is the generation of older adults we're talking about now in terms of the expansion of prescription drug problems. Having said that, we know that this is a very heterogeneous group. Folks have extremely individual characteristics, and anytime we create these artificial constructs like the baby boom, or for that matter older adults, we know we're talking about an incredibly diverse group of people. So when we're trying to provide treatment for groups that are not homogeneous, it's very difficult to construct and design service delivery interventions that are appropriate for groups that have that much diversity. And two of the issues that I think, or actually 3 of the issues I think, that really promote diversity or where there's that generate the kind of diverse conditions amongst older adults are co-occurring disabilities, and down here we use the term co-occurring to really specifically deal with alcohol, drug abuse, and mental illness, mental health disorders. So we know that the population of older adults is affected by co-occurring disorders at rates in excess of the general population, and we use this term coexisting disabilities to deal with alcohol and drug abuse disabilities along with other physiological disabilities or mental health disabilities. So coexisting disabilities is an inclusive term. Co-occurring disabilities is a specific term. But the reality is that older adults are going to experience those issues at rates far and above the rates experienced by the general population. And our research here, and it's the area that I've worked in for about 15 years, I guess, our research here has indicated that whenever we have people with disabilities of either type, either physiological or mental health disabilities, that it's going to predict a very significant increase in the amount of substance use disorders that they experience, and also in terms of the complexity of those disorders. So this issue is kind of compounded by something called iatrogenic dependence, which is dependence that's caused specifically through prescription of psychoactive substances. So we know too that as people, particularly physiological disabilities, are prescribed medications for pain or for other disorders, it puts them at greater risk to actually acquire dependency. And there's a lot of debate about this. There's considerable debate, in fact, around prescription, particularly opioids, prescription of opioid medication, and how dependent, what the correlation is between prescription of those pain medications and substance use dependence. And I think we're seeing now that this debate has become so severe that it's really behind many of the changes in the current DSM-5. That rather than kind of resolve the issues of prescription drug dependence, we're going to get rid of the term dependence, which is kind of fascinating to me, but we can talk about that a little bit later on. This is where I wish we kind of had a live room where we could discuss this. Another issue with older adults and prescription drugs are just the realities of the challenges of aging, and some of the things we're talking about there are kind of the issues that go along with grief and loss, the issues that go along with isolation, the issues that go along with changes in vocation and social environment, living conditions. So we're dealing with a very complex population that has a history of involvement with illicit and illicit substances, with highly individualized characteristics. They have often challenges on multiple dimensions, including physical and mental health disabilities, and then the challenges that go along with just the natural process of aging. So we had prescription drug use, misuse, and I guess for the time being we'll say abuse and dependence to that mix, and you've got consumers that really have a very complex level of need. Adolescents, on the other hand, are obviously have a very different set of challenges, as we're talking about treatment. And, we're more likely to see adolescents, the broader group of adolescents, involved in experimentation, use, and misuse. But having said that, the work of Bill Miller back in, I think, the mid-90s, late 90s, when he was kind of trying to identify the pathways to dependence, some of the data that he found on adolescent use, really indicated that when we have early use of any kind of substances, it's going to predict dependency, and early use also predicts co-occurring disorders. So again, we're talking about adolescent population, that this is a population that may have, again, multiple needs on a number of different treatment dimensions. One of the things that's kind of fascinating to think about adolescent use. I mean, again, I think most folks who are probably on the conference today know my history, at least briefly, and I think about my own recovery and my own experiences in use pre-recovery, and my involvement in the alcohol and drug abuse subculture, the kind of culture of abuse, was almost immediate when I got involved in any use at all. So I guess what I'm saying here is that you think about, and for me, I worked with adolescents for about 10 years. Most of those young people, when they got involved in alcohol and drug misuse and got involved in developing substance use disorders, as they began to experiment more and more, and as they began to use more and more, they get more immersed in the drug and alcohol use subculture. With prescription drugs, this change in acquisition, meaning in terms of acquisition that they're no longer getting prescription drugs off the street. I mean, what's happened now is prescription drugs, there's considerable evidence supporting the idea that when adolescents are using prescription drugs, they're acquiring them through their parents, they're acquiring them through their friends' parents, acquiring them through other family members, friends' family members. This really changes the shape of I think, our consumers' identities. And if we start thinking about what their social needs are, we start thinking about how we view or how we characterize, the consumer populations that we serve, they may be really dramatically different than consumers that we've served in the past. And rather than being immersed in the drug subculture, they may be young people that really have low levels of immersion, but have instead acquired their substance use disorders through this experimentation and acquisition of illicit substances used illicitly through their parents. So lastly, again, and we talked about the challenge of aging, we know that adolescents have their own challenges in terms of development. There's a lot of worry right now in the research community about the effects of opioids on young persons. There's been some real interesting studies done recently that talk about the impact of opioids even on first use on adolescent neurochemistry and neurophysiology. So I think we're really concerned about how prescription drug use and misuse can result in long-term impact and developmental deficits and perhaps even neurophysiological, neurochemical deficits in the long run. So pretty significant effects. All right. Got a delayed reaction. Okay. When we train rehab counselors to address alcohol and drug abuse disabilities here at SIU, we use something called the biopsychosocial spiritual model, the BPSS model, and I think most everyone's probably familiar with the BPS model and maybe even the BPSS model. I think the first person to really talk about a spiritual dimension in this model was a person named Dr. Eileen Wolfstein at New York University, and really like this model because I think it's obviously it's more holistic, but I think it really gets at many of the issues that we've been familiar with in the recovery community around identity and self and grounds of being and value that come along with spirituality. So I want to just talk a little bit about how BPSS I think is affected when we're dealing with prescription drug use and misuse. Biologically, I mentioned earlier this issue of when is dependence not dependence, and I think Dr. Carlton Erickson, who spoke at IATA a couple years ago, if you recall, discussed this issue, and he's written about this issue of when is dependence not dependence. One of the problems in the current DSM-4 is that folks can have tolerance and withdrawal. They can meet those two criteria, which historically we've kind of regarded as physical dependence. That the presence of tolerance and withdrawal is synonymous with physical dependence. And part of the problem has been that because of that kind of idea that dependence is dependence, that when folks have tolerance and withdrawal, then they somehow are qualified for substance use dependence diagnosis. And as we all know, probably on this call, the current structure of the DSM-4 says that you have to meet 3 of 7 criteria in order to be diagnosed with dependence. And I was not involved in the writing of the DSM-4, and so I don't know what they were thinking, but I suspect that part of the reason why they said that there needed to be 3 criteria was just for that very fact that we do have folks out there that seem to have tolerance and withdrawal who are not dependent. So let's talk about this a little more, because I think this goes to the heart of many of the challenges we're going to experience with prescription drugs. There's considerable evidence that among the population of folks in the United States, we have adults and young people who are using prescription drugs in a way that is compliant with the boundaries of their prescription. They're using the medications as prescribed. They're using the medications appropriately, and they have tolerance and withdrawal as we've defined it over the course of our treatment history, and yet they do not seem to be impacted in other major life activities. So what has been identified is that we have a number of people who are using prescription drugs in a way that appears to be safe and appears to have no long-term impact for them in other areas of their life other than the physiological dependence, that the impact seems to be purely on this kind of medical dimension or biological dimension. For that reason, I think, amongst others, including the fact that many researchers don't like the term abuse, and there's been a lot of controversy around this dichotomous diagnosis of abuse and dependence and how we fit people in those two different slots, if you will. It looks like DSM-5 is going to move to a continuum where we just talk about substance use disorders in general, and we get rid of the term dependence. And I guess for me, I have a lot of ambivalence about this. I certainly think that there are folks out there who are using medications as prescribed who appear to not be affected significantly in other areas of their life. But I worry a lot about getting rid of the term dependency, and even though there's a lack of clarity around this particular class of drugs, I'm not sure that that lack of clarity should be driving our conceptualization of the diagnostic criteria. So again, next point here is this idea of substance use disorders, that we're going to, substance use disorders definition and this use of continuum. So anyway, I just want to talk about that because I think it's the whole argument, the whole challenge is being driven by prescription medications. Now, the proponents of this change talk about, I think, the fact that it may allow for consumers, particular consumers with chronic disability or other chronic medical issues, to be able to receive the medications they need to control pain. And that one of the challenges in the current model is that physicians and consumers are reluctant to take opioid medications to deal with their pain because of the risk of dependence. So the argument goes that by redefining how we conceptualize dependence, it will make medications more available to folks. My opinion about this is that maybe making more medications available may not be the best thing, given what we know about the expansion of the prescription of these medications so far. So anyway, the next point, I guess, is when is dependence dependence? And I think one thing we've all recognized at this point is that when we have people who are using benzodiazepines, we're having folks who are using opioids, that we may have pretty sophisticated or pretty complex needs for detoxification services. Certainly we're going to need medication-assisted therapy, medically assisted therapy, and we have the potential for significant risks in terms of medical or physiological consequences. Again, with the older adult population, we've tried on many occasions to construct programs here in Southern Illinois, really starting in about 2005. We've been working to try and construct adults-only programs to serve adults who have alcohol and drug abuse disabilities, because we know that, again, they're experiencing it at very high rates. One of the major challenges we've had in developing programs here, and I don't know if you've had those same challenges in other parts of the state, but we have a major problem in terms of getting medical facilities, medical professionals who will participate in treatment and who will provide detoxification services, and that is because of the complexities that go along with prescription drug dependence. One of the issues is that, as we did a number of focus groups in one of our earlier projects and found out that there's numerous older adults around who have been prescribed medications for a very long period of time. They're prescribed multiple medications, and physicians were very reluctant to try to detoxify them, given the complexities of just the quantity and duration of the prescriptions that they were using. Another thing that came up with older adults that's kind of an older adult specific issue is just the whole issue of medical frailty and other co-occurring medical disorders. So if you're thinking about setting up a program to kind of deal with older adults and prescription drug abuse, I mean, it's something that you're going to want to explore very carefully is how are we going to guarantee that we can keep consumers safe, and how we can protect their physical health when they enter into treatment, because it really is a dramatic challenge. Psychologically, one of the interesting things about adolescence that we've been learning is, and I think this was done at Brown University about a year ago or 18 months ago, that they had begun to study the immediate impact of the use of opioids on adolescents, and studies have begun to reveal that adolescents begin to use opioids, there's an immediate and permanent change in neurochemistry, that when adolescents use Vicodin and OxyContin, particularly Vicodin, that it really predisposes them to developing dependence as we currently define it much more quickly. So anyway, I just think that's worth discussing. Relapse, our current program that we're working with, again, it's a matrix model program that we were using for methamphetamine, and now our partners over at H Group, I think, are using a lot for prescription drug abuse. Our own experience is just clinically and supervising our folks out in the field here who are in practicum internships through the Rehab Institute. We're really concerned about relapse, that relapse seems to be something that, prescription folks who are experiencing prescription drug use disorders are experiencing at higher rates than perhaps some other drug-specific behaviors. Anyway, what we're hypothesizing at this point is that there's a couple things that may be driving that. One, of course, is accessibility. That prescription drugs are very accessible at this point. It's easy to although I think maybe less easy than it was a couple years ago, it is still pretty easy to acquire prescription drugs. I just recently changed physicians, and I had a little fun with them. They were interviewing me when I changed. I said, well, I need to get my appointment quickly because I have some prescriptions I need to fill. And they said, well, what kind of prescriptions? And I told them, well, not much, just my Dilaudid prescription and my OxyContin Vicodin prescriptions. And they got kind of upset. Actually, I just needed to change my blood pressure medication, but I got them going pretty good. And I think that's a promising sign that that we're really being more careful about prescribing these medications. But anyway, accessibility is still a big issue, and I think we've had several folks that we've worked with here as consumers, and I've actually had a couple recovering students that have relapsed. And I think a big aspect of that was just the ease that they could go on the internet and have prescriptions delivered to them in a very short period of time. I haven't seen people writing about this much, but again, as a person in recovery and a member of the recovering community, one of the things that I've noticed is that that it may be more difficult for persons who have a history of prescription drug misuse to actually be able to identify in the recovering community. That the recovering community may not, at this point at least, be as open to persons who have histories of prescription drug problems. And I think this kind of, at least in my experience, and again, this is just my direct experience in the community, kind of speaks to the complexity of the issue. That one of the things historically that's happened in the recovery community has been that if a physician prescribes you medications, then we recognize that as recovering folks, we're not doctors, and we don't have a right to really question that. So there are many people who are using prescription drugs in the recovering community for appropriately and without necessarily any negative consequences. And there's other folks now who are having significant consequences to prescription drug dependence. And I think that lack of clarity and confusion can really make it problematic for folks to be able to participate in the recovery community. I mean, it's not easy. It's not a cut and dried thing in terms of being able to identify as you enter into recovery, as you would perhaps with folks who have, I don't know if there are any of these folks, but people have kind of pure alcohol dependency. We're just talking about, well, okay, we're going to abstain from alcohol, and then that's what we're talking about here in our meeting. I think a related issue to that is the idea of social permission. That certainly, it's much more permissible to use prescription substances in our culture. And again, this has, I think, been this pattern of permissiveness in terms of using psychoactive substances to improve the quality of our lives has been going on for a long period of time. And I think it's much easier for folks, at least in my experience, it's been easy for folks to begin to use prescription drugs again. They're not going to fail their drug test at work. They're not going to, their vocational consequences aren't as present. Social consequences may not be as present immediately because of that reality. So again, psychological and physiological, if we read our DSMs, we'll find out that those are really the same thing, mind and body. There's no real mind-body separation. So that, we also know the phenomenon of craving exists, and if we don't treat people with medication-assisted therapy, drug-assisted therapy, it's very likely that, this kind of psychological craving, which of course we know is really physiologically driven, neurophysiologically driven, can also really contribute to relapse. So even though that's under the psychological section, I think it's really mind-body is difficult to differentiate. All right. Okay, so one of the things I think that then probably comes up next is the issue of assessment and psychological or biomedical assessment for persons who have prescription drug use disorders. And I think one valid question that we need to ask is how are, for anyone who's using prescription drugs, how are these medications affecting their overall mental health? And to my mind, this is maybe one of the most unclear things that we have to deal with. I mean, it's an issue where we have maybe the most ambiguity. It's hard for me to imagine as a clinician and consumer and recovering person, that someone can be using opioid medications, benzodiazepine medications over the long run and have it not affect their mental health significantly. And yet I hear lots of evidence of folks who allegedly are able to do this. And again, people that I really respect, like Carl Erickson, other folks in the medical community, have made powerful arguments that folks are able to use medications in the long run, medications of these types in the long run, without having significant psychological or physiological consequences, which, that would be the bar we'd have to rise above in terms of diagnosis in the current DSM and I think in the future DSM. I think another issue that comes up is, how do we determine causality? And, we all know from our involvement with co-occurring disorders how difficult it is to sort out whether there were some mental health challenges prior to the use of illicit or illicit substances, and whether the illicit or illicit substance use is driven by underlying mental health disorders or vice versa. I think we've kind of resolved this by saying that, we're going to treat everything concurrently and forget about, chicken and egg arguments. But I think in terms of prescription drug use, we're re-entering that reality again of, how do we know whether the drugs that have been prescribed are really causing significant impairments in terms of mental health functioning and overall mental health. Again, pain management comes up, I think, in all the literature that we've looked at over the years with older adults. That there's two challenges here. One is can people use these kinds of medications in the long run successfully without any kind of secondary impairments? And the other issue, I guess, for us as we've looked at this over the years on my research team has been what happens in an environment where there's very little alternative approaches to management of pain. So really it seems like the consumers that we deal with here in Southern Illinois, medication is the only pathway that they're presented with in terms of pain management. There doesn't seem to be a lot of alternative means of managing pain. So, it's kind of an issue of, well, either you use the opioids or you suffer. And we don't like that when we hear it. And we think there's other ways that can be utilized to manage some levels of pain. However, it's a major problem in terms of assessing, when we're going to use the medications, when we're not, what are the consequences of those things. So one of the things that we've argued about, and one of the things that I think is important to recognize is, how can we really begin to assess impairment in major life activities? So, as a rehab counselor, I'm a certified rehab counselor, we use a different set of terminology, I think, than most alcohol and drug abuse counselors do, or most alcohol and drug abuse treatment settings do, in this idea of major life activities and substantial impairment, and what does it really mean to have an impairment that limits your ability to function in major life activities? And I wish that would be the direction that we would go in terms of assessment, that we really start to think about, how do opioids affect our ability to interact in our family situations? How do opioids affect our ability to, interact in our vocational situations, our educational situations? So, that how are they really affecting our functioning? What are the physiological and psychological consequences, and how do we really measure those things in terms of major life activities and substantial impairment? And I guess one of the things that I think is just a signal that a person who's using opioid medications is affected in multiple dimensions of their life is the fact that the warning labels on the medications themselves basically say, look, if you're taking this medication, you shouldn't operate, machinery, or you shouldn't operate, anything. It's kind of the same definition we would have used for substance abuse, that persons who are using substances that could impair them and then put themselves in dangerous situations. That's a sign that we would have diagnosed someone in the past. One of the signs we would have diagnosed someone in the past with problem substance use behavior. Well, I guess the question I would have in terms of how we assess the impact of prescription drug use also revolves around this idea of, well, if I'm on these medications every day and I'm driving impaired every day because I'm taking these medications every day, or I'm working impaired every day, what level of impairment does it take for someone to really recognize that that's a substantial impairment for their lives. And I've not seen a lot of good discussion about that in the research literature. And I think that, for us as alcohol and drug abuse counselors or treatment professionals, when we're trying to assess the impact of these medications on the lives of individuals, it becomes very difficult to really establish, when the use is crossing a line. And I don't think the new DSM-5 helps as much in that regard. Socially, in terms of the BPSS model, moving on to the social aspect, one of the things I think becomes really significant for adolescents is parental and familial use. Again, we know that adolescents are getting prescription drugs directly from family members or friends. I think this is something that has a dramatic impact in terms of treatment. I mean, if we want to we just started the adolescent community reinforcement approach here, which is very family dependent. If I'm going to treat an adolescent with a prescription drug problem, a prescription use disorder, how am I going to address that disorder in a family where the parents may be using those substances as well, that, family members may be using those substances, grandma and grandpa may be using those substances. I think it really forces us to think, come up with some new ideas about how we address, family involvement, how we discuss family involvement with our consumers. We know that peers are using more and more, that the rates are very high for peer use. And I didn't include today, I thought about including some of the SAMHSA data on incidence and prevalence, but I'm guessing most people have seen that data, and none of it's very fresh. I maybe have a little bit of it left in this presentation later on, but I don't think I kept much of it because SAMHSA hasn't really been reporting it, in a timely fashion. But we know that many peers are using on a regular basis. So how are we going to address that? And then again, the issue of availability. For older adults, in terms of social needs, we think that the impact on medical treatment models is significant. And again, what we're talking about here is that older adults are likely to have much more interaction with the medical community. They're likely to have much more interaction with physicians, maybe home nurses. They're going to have much more involvement with medical case managers. And one of the things that Abraham Maslow said years ago that we discuss here in this regard is, he said, if the only tool that you have is a hammer, you're going to see every problem as a nail. And one of the consequences we think of older adults having so much interaction with the medical community is the medical community tends to have a solution to most of their problems, which is medication. And also, it's realistic to state that most consumers expect the medical community to medicate them. So it's kind of a mutually reinforcing delimiting factor that we expect medication and we rely on medication, and so therefore there's more medication. And so kind of the social reality for older adults in some respects is that the professionals they have the most contact with, frequent contact with, are medical professionals who are prescribing medications. Also with older adults, there's older adult specific challenges like the impact of retirement that changes vocation, changes in housing, issues of loss, grief, isolation really, play into the need to perhaps want to self-medicate. And of course, in particular with opioids and anxiolytics, we'll be talking about, kind of management of disability or pain or related anxiety that comes around with, these other issues. So we know socially that this is a problem. One of the things we've talked about with older adults, and when we've done focus groups down here in our needs assessments, and we've done work with programs here in Southern Illinois with older adults, is also the impact of isolation. That socially, many of these older adults are not in connection with individuals who can recognize when they've begun to really experience impairment. Many of the folks who knew them best may not be around, may not be physically present, they may not have the same level of interactions. So it can become really difficult to identify when individuals are really starting to suffer and struggle. And we've had a lot of discussions too about who should be the one to really identify that. I mean, how do we change that reality? How do we impact the reality of identifying folks who can really screen and intervene when older adults have problems. And the reality is it's pretty difficult to identify folks other than individuals in the medical community, and also maybe some folks in the community rehab programs, home health folks, who may be able to do that. But it seems problematic. Another aspect of this is, kind of social expectations, that, we expect older adults to be using medications. In some circumstances, when we're talking about older adult use, we're not talking about alcohol and other drugs, but certainly with alcohol, we know there's an expectation that, once you retire, once you don't have life responsibilities, if you want to drink more or use more, that that's okay. And we suspect the same kind of phenomenon is happening with prescription drugs, that folks are much more willing to tolerate and accept misuse of prescription drugs amongst older adults, particularly just merely because they're older adults. Spirituality in terms of ground and being of value, and again, this is kind of Eileen's model of spirituality, that people really set their identity up and create their values, and their grounds of their identity and values are driven by their substance use in the cases of folks with substance use disorders. With adolescents, we talked a little bit about how entry in the drug culture may not be the issue, but certainly kind of your perception of yourself and when you begin to misuse substances is going to change, your identity is going to change. You're going to start to see that right away. For older adults, it's really more severe spiritual consequences, I think, in that you may have much more helplessness and loss of control factors coming into the use and misuse of substances, that folks are not feeling emotionally healthy, and they turn to physicians for help, and maybe misunderstand what's happening in their lives and get mismedicated as a consequence. I think also with older adults, we've seen a lot in the research and also in our own work with older adults that they really feel pretty powerless to kind of influence the service delivery systems. They really feel pretty powerless about their ability to really be able to have any kind of impact. Folks around older adults really feel pretty powerless when they see older adults being over-medicated. We talked a lot about over-medication in many of our focus groups that we did here in the 2006 study that we did here in Southern Illinois. One of the things we heard again and again was, well, we think maybe mom or dad or Aunt Joe or whoever or Uncle Tom have too many medications, and we don't know what to do about it. We heard that a lot. That folks really feel kind of powerless, and I think spiritually, folks get pretty beaten down by that, and they feel that kind of, again, that sense of helplessness and loss of control that we associate with problem substance use later on. I do have a little bit of statistics here for you. Just, I think in terms of older adults, it's really very interesting to note that even though adult persons or persons over the age of 65 only comprise 13% of the population, they're prescribed 33% of all medications in the United States. So, again, we're talking about accessibility, availability. That's a pretty significant statistic. In addition, older patients are likely to be prescribed more long-term prescriptions, as well as multiple prescriptions, which could potentially result in unintentional misuse. Again, when we did work with older adults here, we found that many of them didn't really understand the medications they were taking. They didn't know why they were taking them. They weren't really sure how medications interacted with one another. They didn't really feel confident about conversations with physicians in this regard. They were really kind of apprehensive about introducing the topic of medication mismanagement. They're really reluctant to raise those issues. We're not going to talk about this today, really, but it's also worthy to kind of note that a large percentage of older adults also use over-the-counter medicines and dietary supplements along with prescription medications, and that can also cause problems. And even some of the medications that we think are pretty harmless can cause long-term consequences when we're using them, overusing them, or using them in ways that fall outside of the parameters in which they're intended. Older adults are at risk for prescribing or prescription drug abuse in which they intentionally take medications that are not medically necessary. Again, I think when medications are available, one of the findings that we found in our study and what we've also found in the literature is this idea that there is intentional misuse, and I think we're always kind of thinking about older adults in terms of unintentional use or making mistakes or iatrogenic dependence. It's promoted by physicians, but let's not forget that, again, we're talking about the baby boom generation here. So we're talking about a generation of folks that have more experience with illicit drugs and intentionally misusing or inappropriately using substances than any other generation. So, I mean, again, I think we start talking about folks who are over the age of 60 or over the age of 65. We think, well, if they're having problems with prescription drugs, it's probably not their fault. Well, it may well be that they're intentionally using, and we certainly found lots of that in our studies down here. Again, because of high rates of comorbid illnesses among the elderly, changes in drug metabolism with age, and potential for drug interactions, prescription and OT drug abuse or misuse can have more adverse health consequences among this age group. So, I mean, this is where I think we get into some real confusion in terms of assessment and diagnosis, and we get into some real confusion in terms of really measuring the real consequences of prescription drug use, because given that these things are true, particularly issues around drug metabolism and major changes for drug metabolism and potential for drug interactions, we start thinking about this DSM criteria around having significant adverse psychological and physiological consequences. It seems like there's very great potential for that, and how do we really measure that? How do we ascertain the source of those challenges? Becomes pretty complex. All right. DASIS, this is DASIS status, SAMHSA treatment data. One of the things that was kind of interesting, and again, if you compare these two slides, says persons over 65 comprised only 0.6% of the total admissions in the United States. We look up here that although persons over 65 years comprise only 13% of the population, look, if persons over 65 are 13% of the population, and they're prescribed 33% of all medications, then it doesn't make sense that they're only going to be 0.6% of the total admissions in the United States. We actually found that was the same statistic we had in our studies here in Southern Illinois as well, that older adults almost never made it to treatment, and it's problematic. And when they do make it to treatment, they don't make it to treatment for prescription drug abuse. We'll see that in just a little bit. What they're usually treated for is alcohol, which is the next statistic. Usually folks in this 65 to 69 age group made up the largest portion of the population. That made us really think about, as we have folks who have increasingly long lifespans, folks who are living over the age of 70, how are we going to get them into treatment? Right now we don't see many of those folks entering treatment. In fact, we don't see many folks entering treatment 65 to 69. But as folks age and have better health, hopefully at least, many more of them may need treatment post age 70. And I know in my own case, conceptualizing how we deliver treatment to folks who are in that age group is problematic. Between 1995 and 2005, again, this is why I didn't use a lot of stats, because this stuff's still pretty old. I wish SAMHSA would update their older adult data. Primary opioid admissions increased 6.6% to 10.5% of all admissions age 65 and older. So we are seeing some older adults hit the system, but again, I guess given the quantity and quality of medications that are prescribed, you'd expect that percentage to be much greater. 2005, this age group comprised approximately 37 million people in the United States, 13% of total population, and there were 11,300 admissions age 65 or older to substance abuse treatment. That's in the entire United States. That's pretty problematic. Admissions rate for older adults 65 or older is 30.7 per 100,000, which is considerably lower than the 707.3 admissions per 100,000 for the population younger than 65. You can see the table here, and I won't go through all that. You guys can, I think Pella's going to send everything out. You can kind of look through. I guess the one thing we would note here is that, if you look at the percentage of the total populations who are admitted for alcohol, we're talking about a range between 75 and 84%. And look at the range for tranquilizers and sedatives and opiates. Those are significantly less. We do see an increase in the number of people seeking treatment for opiates, post 2000, but significantly less than I think what we'd expect. We did our studies here in Southern Illinois with older adults One of the things that folks predicted, the folks that were in these studies were clinicians and family members and treatment administrators, alcohol and drug abuse treatment administrators, and other key stakeholders involved in work with older adults. They kind of predicted that we would see alcohol treatment, benzodiazepine treatment, and then treatment for OxyContin, Vicodin. They also told us that they thought no one was screening for prescription drug use in older adults, that the services were by and large inaccessible for older adults, and that there were significant challenges in integrating the medical and alcohol and drug abuse treatment systems. Those were kind of the main focus. And so we looked at the DARTS data, and we actually looked at the 2005 data. We got this at the end of 2006, I think, and looked at 2006 and 2007. We were crunching the numbers. You can see that in the 2005 data set that there's very few folks who are actually getting treatment for primary diagnosis of benzodiazepine use disorders or opioid use disorders. That most of the folks who are getting treatment in Illinois were alcohol related. You might look at the heroin numbers, and this was suspicious to us when we got the data. And we worked with the folks at DASA to look at the data, and we said, oh my goodness, what's the deal with heroin? It's a heroin epidemic in older adults. What we think happens with those numbers is that we have a significant number of people on methadone who've been on methadone for a very long period of time. We have an older client population on methadone, and it has driven up the numbers for older adult treatment. And keep in mind, we're saying older adults here. We're talking about age 55, and you might say, well, golly, Shane, you've been talking all along about older adults 65 and over and older adults 70 and over, and now we're talking about age 55. What's that about? It seems like we've changed the rules, and the reality is we did change the rules, because when we looked at 65 and older, there were almost no treatment admissions in that population. So we had to lower the age to 55 to get any kind of significant numbers in terms of people that actually got care. So, in the state of Illinois, we think if you're over the age of 65, it's pretty rare for you to actually get into treatment at all. So, all right. So, just to kind of close out here, and then we'll have a little time to talk to kind of summarize what's up. We've got the Apollo 13 in Houston. I think we have a problem here. I think there's major problems in terms of screening for kids. I think that we have the most likely candidates to be screeners are teachers and educators, who may be able to really do a screening like an ESPER model, a screening brief intervention model. Parents, getting them involved in the process, I think is going to be increasingly important. We're about to start a new project, a new ACRA project. One of the things we're going to try to do is do some ESPER training with those same folks, also with guidance counselors, with the principals, so that they can begin to recognize when there's problems occurring with youth, when substance use disorders may be beginning. We talked about older adults. There's a number of different ideas about how to really screen for older adults, substance use disorders. We talked about family members. One of the best ideas I've heard really is to use home health workers and also primary care physicians. The best candidates, in fact, we've identified are the PCPs. The question for us, though, and for the projects we've tried to design in that area, have been, that the PCPs are already so overloaded. They have so little time to do what they need to do in terms of managing these very sophisticated cases, complex cases in older adults. They don't want to take the extra time to deal with substance use disorders. Probably the leading person in older adult prescription drug abuse is a guy named Dr. Fred Blow. He says anytime an older adult, and he identifies older adult here as a person over the age of 60, comes in for primary care, that they ought to be screened for substance use. So that's kind of a fascinating reality, and I think no one does that. Then the next question, I guess, becomes, when we have these special populations of either folks who are typically younger than our treatment population or folks who are typically older than our treatment population, how do we deal with eligibility issues? And, if our programs aren't targeted for those populations, then how do we get them the services we need? And do we need to, develop or design more programs, get more programs funded for special populations? As we all know, special populations money isn't increasing in the state of Illinois, given our current budget issues. In fact, we've moved away from kind of special populations models. So, eligibility, I think, is going to be a problem for us. I mean, how do we create programs specifically for youth or for older adults? Another major issue, I think, is appropriateness. If we have this, significant risk for medical consequences, for psychological consequences associated with detoxification from prescription drugs, if we have these very complex medical conditions for older adults, how do we decide when these consumers are appropriate for our programs? And again, I mean, I think this challenge appears now, when we're 20 years into relying mostly on outpatient programs to do our treatment. So while we've decreased the number and the quantity and availability of inpatient, medically managed, medically monitored residential treatment programs, we decreased the availability of those. Now we have a population that I think would probably benefit. And actually, Nora Volkoff said before, and I think maybe in the 1990s, or even she said it lots recently, but she said it for a long time, that this is a population that really needs residential care. Leshner said it too when he was at NIDA. Anyways, the next real issue here is appropriate instrumentation evaluation tools. I have medication appropriateness next. If you want to really have an Alice in Wonderland kind of experience, go through the research literature on determining medication appropriateness, and it's really fascinating. And no one can agree on how to really measure medication appropriateness, and there's been lots of attempts to design standardized instruments that can be utilized to determine whether somebody may be on inappropriate medications. Obviously, the medical community, physicians are not eager to really have those instruments implemented. The possibilities for litigation obviously are significant. So, I mean, we obviously really need standardized instruments which can help us as alcohol and drug abuse professionals to really determine whether somebody's appropriately or inappropriately medicated. But there's a lot of forces in play that are keeping us from really being able to develop those instruments and implement them. Again, we talked about it all throughout the issue today about screening, about who does it, when do they do it, how do they do it, how often do they do it, and there's considerable disagreement about how we should implement screening procedures. We've been really excited about SBIRT down here. That's something we've been really enthusiastic about. The reality is that we did one project with SBIRT not too long ago, and it didn't work out as well as we thought it might. It was just very, very difficult to get the folks from the other allied health professionals we were working with invested in really learning the skills necessary to do screening brief intervention. When I was at the IATA conference in the fall, I heard the same thing from another participant. I don't want to say who it was, but they said, well, gee, we tried this SBIRT thing, and they'd also had a very negative experience. So we've been kind of hoping SBIRT was the way out for both these populations, and now we're a little more dubious about how easily implemented that model is. The model sounds great in theory, but it's tough for us to implement it, at least. It sounds like other folks have struggled too. Again, we talked a little bit about DSM-4, DSM-5 criteria in terms of assessment. How do we get medical community involved? How are they affected when we start saying, look, we think this person's dependent? I know my experience with my own primary care physicians over the past 20 years of my recovery has been that they don't really understand dependency. They don't really understand addiction. It's really difficult to get things done accurately. Again, I'm talking a lot about older adults today. That's probably the population we know the most about in terms of prescription drug abuse. Fred Blow says, the expert on alcohol and drug abuse and older adults, says that the DSM criteria don't work at all for older adults. That by and large, the criterion are rendered kind of ineffective when we deal with older adult and aging issues. I guess the other piece that worries us down here a lot and worries me personally a lot is, that the number of people who are new non-medical users of pain relievers increased from 573,000 in 1990 to 2.5 million in 2000. You know, I haven't seen the new data for 2010. You know, hopefully we'll get that from SAMHSA soon. You know, there's this huge increase in the number of people who are using these prescriptions, and there's a huge increase in just the prescriptions in general, so that we have to deal with this iatrogenic dependency. So I guess, you know, one of the things we're really increasingly worried about is, you know, the impact of just this broad swath of medications going out to an incredibly larger number of folks than what we've ever had in the past. I guess we'd be remiss also if we didn't talk at least briefly about, you know, the impact of advertising. That, you know, the impact of advertising prescription drugs is a very recent phenomenon. It started in the 1980s, so we've really only been doing that for about 25 years. We're really concerned, I think, about, you know, just this expansion in the quantity of folks who are using very high-powered medications, very addictive medications, and the use of advertising, which really coaches them to seek these medications. It's a really unique phenomenon. I don't think we've ever seen anything quite like this in our history. Again, case management for this issue is, I think, incredibly complex. We've had a lot of challenges here in terms of setting up medically assisted therapy, of getting physicians who are trained to use, you know, drugs like Suboxone. You know, we're really in favor of doing medication-assisted therapy. It's been really hard to get it implemented. I think that we're going to have to really build the bridges. You know, I know Bill White and other folks in Illinois have been leaders in terms of integrating recovering community into our professional treatment service deliveries, or our professional service delivery systems models for treatment. I think that prescription drug abuse treatment, and particularly medication-assisted therapy, doesn't sit well with many people in the recovery community. I think it's very hard for them to kind of conceptualize how that can be appropriate. So I mean, I think while we're on the one hand, we're really trying to get recovering persons reinvested in treatment, and we're trying to include the recovery community more and more. Prescription drug treatment, prescription use disorders, I think really places a lot of unique challenges to that relationship, and I think, you know, the recovering community may not be in a position to kind of readily participate. Again, I think our attitudes, beliefs, values, and behaviors in the recovery community may not be consistent with the kinds of things we need to move forward. We talked a lot about coexisting and co-occurring disorders. I think in both populations, co-occurring disorders are a major problem. We think coexisting disabilities are more a problem in older adults, but young people with disabilities also experience alcohol and drug use disorders at rates far in excess of the population. So when you're working with these populations, it's much more likely that you're going to have cases that are complex on multiple different dimensions. I think that, you know, we always stress the need to integrate marriage and family therapy and treatment. With these two populations, I think it becomes even more important. Obviously, with adolescents, we're going to have a tremendous need to integrate family therapy in our approach. We talked about earlier that many of the adolescents are getting prescription drugs from their family members, so that's problematic. With older adults, the transitions and again, grief and loss, you know, the kind of changes that go on in long-term relationships in older adults, I mean, I think marriage and family therapy becomes really important. Education, vocational, obviously, with young people, you know, we have to understand the impact of prescription drugs on educational success and academic success. We know that academic failure predicts increases in substance use disorders, so we want to make sure that we're helping kids be successful. On the older adult spectrum, we know that the changes that come about through retirement and changes in status due to vocational changes are significantly impactful, and that many people are become more at risk for substance use disorders as a consequence of those changes. And then I think linking community rehab programs, particularly with older adults, becomes a significant case management challenge. All right, I'm going to take a deep breath here because I've been going like crazy. I've got more stuff to do, but Mary Jo, it looks like we're about 10 after 11. I'm a little concerned with our ability to facilitate discussions on the chat. So why don't we go ahead and see if we have some questions in the chat that we can kind of respond to. and that way we make sure we have time for everyone to kind of be part of things. What do you think?
That will work just fine. I've been watching. We've had a couple of technical questions, but I haven't seen anyone.
Well, let's take a pause, and I'm going to take a drink of my tea
Sure.
here, and we'll see if anybody has any questions.
I'm not seeing any raised
I'm not
hands or
seeing
anything
anything
in
either.
the
Are we
chat.
okay out there, guys?
Oh. I see a couple hands raised now. If you could send a chat down at the bottom. I think I can repeat the question that way.
Okay. I'm still seeing IATA's webinar will begin shortly in the chat window.
Okay. Here's a question.
So,
How do you?
I'm not seeing the questions come up.
Let me read them back to you so the entire group can hear it also. How do you think the aging of America will affect decriminalization of legalization of marijuana or legalization?
Boy, I think that would be a topic for another training. Because we're really talking about prescription drugs. I mean, I don't know. I mean, I guess what you're thinking of there is, you know, because this is a generation that's had more experience with illicit drugs, that they might be more open-minded. It's fascinating to me that this generation seems to get more conservative as they age. So I don't know if there's any hope for that or not, but it's a great question. This is what did I'm trying to remember what Winston Churchill said, right? He said, if you're young and conservative, you have no heart, and if you're old and liberal, you have no brain, right? So I think this generation is a great example of that. That when they were in the 60s, they were very liberal, and as they become older, they become more conservative. So. We got anything else coming up, Mary Jo?
I thought I saw another hand come up, and now I don't see it. Any other questions?
All right, well, let's,
hold on
if we don't have any questions, I'll take another.
Oh. Wait, we do. I'm sorry.
Oh, we do? Okay.
Have you been seeing any Ambien abuse?
You know what? We've heard discussion about folks using Ambien. We certainly heard lots of discussion around negative consequences of Ambien. That was when we did, particularly the older adult research we did, we heard lots of discussion about negative consequences. I don't have any great data about Ambien misuse, but I mean, we did hear anecdotally when we did the focus group research. We heard about you know, folks having very negative experiences with Ambien. I mean, I think it's like anything else. You hear about the negative experiences rather than the positive experiences most of the time. Anything else?
I'm waiting for one reply there, but
okay.
I think might be a little time delay through the connection, right? Well, I guess not.
I think the issue with Ambien, when we talk about Ambien, is like so many other medications. there's all kinds of potential side effects like ataxia and motor coordination. I mean, this begs the issue again about psychological and physiological consequences of prescription drug use. I mean, we say, okay, well, look, people can have tolerance and withdrawal, but not be dependent. My argument would be, look, if I'm using a medication like Ambien, where I can have problems with my motor coordination, my libido goes down, I start problems with amnesia, I start having impaired judgment and reasoning. I mean, that's just a list of side effects that come from the manufacturer. How can a person who's doing that long term not have significant impairments? So anything else out there?
I don't think so. Well, I think
well, I know we were scheduled for an hour and 15 minutes kind of at the IATA conference. I got a little more time scheduled here for folks if they have any other questions or have any other concerns. I don't have anywhere to be for a while. Otherwise, we can kind of close it down. I've got a few more things. I think most of the other slides we have I've got some prevention slides, which I think you guys will be able to use, but they don't really require a lot of explanation.
Did you post your contact information already? Can we do that again? I have one that's
I
having
did that earlier, but we can go ahead and do that again.
We have one that's having a hard time with his connection and wants to call you, if that's okay.
Yeah, I can see somebody kind of dipping in and out. Here's my contact stuff again. Oh,
okay.
There we go. There we go. Well, this was very interesting, Mary Jo. I hope folks are doing okay out there.
We're not seeing your contact.
Oh, you're not?
No.
Okay, hang on here. Show my screen. How about now?
Yes.
You got it now?
See the email address. Do you have a phone number?
Waiting for your screen. Oh, yeah, I don't have any of that on that slide. I have to. You can. Well, it comes back up here again. If you for the phone number and stuff, if you just click on the link, it'll take you to my Rehab Institute page.
Okay, I'll make sure. There we go.
And that has everything on there. Yeah, see that up there?
Yep. 618-453.
All right.
8284.
And actually, if you go to, let me show them my other page here too. That's actually my page through the, if you go to SIUC and you just put my name in, actually that took me back to that one too. Let's see, here's my other page, the Rehab Institute, which has links to everybody who's on the research team, and
okay.
And you can find all of this.
Great.
Are you seeing that?
Yes.
Yeah. Cool.
All right.
So you can get the link from up above there if you want.
Okay. Well, thank you for a great presentation, Dr. Koch. An evaluation will be mailed to all participants following the webinar. IODAPCA CEUs have been approved, and participants will receive verification via email. IATA thanks Dr. Koch for presenting the webinar, for your participation. We hope you will attend future webinars, and I hope everyone has a pleasant day. And we will sign off now.